Good evening, everyone. We can see you're still joining the webinar. And first of all, let me say a couple of words as the introduction. First, let me thank Quantel for organizing the webinar and inviting us to share our experience regarding floaters and treating floaters in the procedure, which is most often called Vitreolys. I guess we all share very common thoughts that Vitreolys has changed a lot in our clinical experience. And that's the main reason we want to share our experience with you, to let you start with Vitreolys if you haven't started yet, or continue your experience if your outcomes are still something to be more advancing you in terms of how you treat your patients. I have a great honor to introduce three speakers, and I guess the names are very familiar for majority of our European audience. Let me start from the lady, Dr. Roxana Fulga. She is the General Secretary of IOFS, the society which we're going to speak about many times during this meeting. And even if right now she is running her own practice in Cologne, since 2019, she has a deep experience in medical retinal treatment. She was one of the first German doctors who performed laser vitreolysis. Then let me introduce Dr. Kaymak, a very well recognized ophthalmologist, especially when it comes to the medical retina field. Probably many of you know Dr. Kaymak for being one of the pioneers in 23 gauge vitrectomy and other medical procedures in this field. Still working in Düsseldorf as far as I know. And finally, it's my great honor to introduce Dr. Klabe, who is not only one of the most recognized ophthalmologists, German ophthalmologists, but also my teacher. Many years ago, he started my education in intraocular surgery. So I guess it's a double pleasure for me at this moment. But speaking of the medical advancements, it's not the ophthalmic surgery in general. It's not just the retinal applications, but glaucoma, corneal transplants, and many other issues. Dr. Klabe received lots of awards for his scientific works, for scientific work, and is the author to over 100 scientific papers and presentations. So it's a pack of people who share their experience with Vitreolys for years, and we had this unique opportunity to speak about it many times. But I guess this meeting should change the way you look at floaters and your patients too, and this is what we count on. First of all, let me ask you to mute your microphones if you haven't done so. I guess it will be easier for all of us to start a meeting like this. As I mentioned, we'll speak a lot about International Ophthalmic Floater Society. We are all members of this society, and we will for sure we'll ask you to join us in the efforts to treat vitreous floaters. And I guess it's a perfect opportunity to share our next events, which would be on November 27th. And I guess when you look at the program, which covers lots of issues regarding the floaters, not just from the perspective of treatment, but it includes the imaging, it includes the diagnostic methods from all the big names in vitreolysis procedure. So I guess it's the perfect time to go on with my introduction to floaters. And I guess when we see patients who suffer from floaters, our first thought for many years has been just try to live with it and try to exist with the problem you have. And this is something I heard many times, not only during my university education, but later on from patients who actually talked about way they communicated with the doctors. When it comes to the experiences with vitreolysis procedure, generally we all start from YAG procedures, which go on towards the vitreous. But the main question which appears in our minds when it comes to this procedure is which floaters to treat and what would be the best way to diagnose patients suitable for treatment. And I guess thoughts about the clouds are the best ones which you can have in your mind. Generally, clouds are something beautiful. But I always have this thought that when I listen to my patients, probably the clouds are the worst thing in their minds and the worst thing in their eyes. So generally, when you look at the nature of floaters, it's the way the patients exist with the shadows present in the same way in the surface of Earth as we see it in our daily life. So this is the main complaint of our patients: seeing shadows, seeing moving objects in their visual fields, which change their perception of vision. So when you look at the vitreous itself, which is the main source of potential problems and potential shadows in the visual field of the patient, let's start from the physiology and how the posterior hyaloid membrane looks like. And when we stain, we can easily see how complex and difficult structure it is. And the way it ages causes numerous opacifications within its structure, especially when it comes to the anterior surface, which is in many situations attached to the lens, and the back of the vitreous, especially in young patients who suffer from early floaters, which are usually in the mid-vitreous, and later on from posterior hyaloid detachments. How do we get floaters? I guess the answer to this question is often something what we hear from our patients, and we know that aging of the vitreous and myopia are two main reasons why we have floaters. And as we know, myopia is going to affect almost 50% of population by the age 2050, according to the World Health Organization. So we are expecting this group of patients to be present in our practices more often. When it comes to floaters in 50+ patients, then generally those floaters are related to the PVD. And the way we treat posterior vitreous detachment floaters is probably one of the most enthusiastic parts of vitreolysis procedure itself. So let's start talking about types of floaters. And I guess we have to mention the name of Dr. Karl Brasse, who developed a perfect way of organizing our knowledge in a sufficient way to see the differences between different groups of floaters. So let me explain you a little bit of how this classification works. And I guess when we look at the first type of floater, it's something quite unusual to see. However, in my practice, I see that from time to time, the operculum, which is actually coming from the retinal tear somewhere in the periphery, it is quite symptomatic. And at the same time, if obviously it's the retina is lasered well, then the operculum itself is very easy to be vaporized. Then the second type of floaters, which is related to the posterior hyaluronic limiting membrane, and a floater which is very well known as Weiss ring. So what are actually Weiss rings? They are usually oval structures which are present in our visual field, very close to the center. And when you look through the central part of your visual field, you see a small dark object moving along with the movements of your eye. They are very well seen during ultrasound examination, and in many cases, people who are starting with vitreolysis procedure are trying to measure distances between the Weiss ring itself and the surface of the retina. Usually the distance is considered to be very safe. However, if it's smaller than 3 millimeters, the recommendations are rather excluding the option for treatment. Type 3, the floaters within the vitreous stroma and sometimes vitreous cortex are usually linear or cloudy types of floaters. So when you look at them, sometimes they can be called amorphic or amorphous clouds. Sometimes, as the picture in the bottom, you can see the linear worm-like types of floaters. Usually those types of floaters are hardest to treat. Sometimes you need 2 or 3 sessions of laser to break them and finally vaporize. The last 2 types would be quite different from the ones which we mentioned before. Type 4, the remnants of the lens capsule after YAG capsulotomy, is something which you can actually see after performing YAG capsulotomies in the way people do it in the circle, so that that actually the piece of capsule falls down to the vitreous cavity, and you can easily see it in the center. Many patients suffer from those opacities. And the last type, type 5, that's connected to the secondary opacifications, usually being post-inflammatory. So which floaters are suitable for treatment? I would definitely say types 1 to 4. When it comes to type 5, they are not excellent for treatment. Sometimes when you find smaller spots which are very well organized, you can treat single ones, but generally the last type wouldn't be considered as suitable for vitreolysis procedure. So basically, when we talk to our patients, we can actually hear that the floaters change the way they see. So many of us think it's just the patient's perception, but is it really true? And that's one of the proofs. That's the outcome of the OCT examination, and you can easily see that the signal strength in this patient at the level of macula was 0. So after performing YAG laser vitreolysis, the signal increases to 7, and you can easily see the epiretinal membrane, and the picture is much clearer. So it's not just the perception of the patient, but looking from the other side, it's the ease of performing the diagnostic process. Generally, when it comes to the floaters and how they are managed with the laser, looking at the potential role of the laser within the vitreous, we know that their location is very important in terms of potential laser work. And we looked at the Weiss ring before, and right now you can easily see what happens to the typical Weiss ring or a bigger floater when you perform YAG laser vitreolysis. From the diagnostic point of view, ultrasound can show us that it's a very local and minimally invasive procedure. And it's very different for vitrectomy, because when you look at what happens within the vitreous, it's a procedure which actually pulls the strands all over the vitreous, even in faraway periphery. So many people think that vitreolysis is causing vast damage to the periphery of the retina. You can actually see from the ultrasound, which I showed in the previous slide, that it's a very local and minimally invasive treatment. And even when you look at the way vitrectors work, you can easily see that pulling the strands is much, much stronger than in terms of laser work. So we'll speak about patient selection later. For me, the most important thing regarding floaters is that the patient needs to have realistic expectations, which is, I believe, one of the most important and crucial aspects of this procedure. My personal experience with Vitreolys started quite a long time ago. It was with other YAG lasers, standard YAG lasers, not the coaxial optics lasers. So in the beginning, when I had new experiences with coaxial optics, I started with very radical diagnostic process, including performing ultrasound, OCTs, and other examinations. And I was very fortunate not to see any problems, and that encouraged me to continue the practice for many years on. But I have to admit that I'm still very conservative when it comes to vitreolysis, even after performing over 3,000 of cases. I guess it's still important to remember that it's still a procedure which is quite limited to specific situations. Are we talking just about floaters? Not really. The procedure is excellent to solve other problems. Obviously, it's our off-label experience in such case, like this hemorrhage, but giving excellent results in terms of final outcomes. So starting the discussion about the YAG laser in vitreolysis procedure, which will be continued by my colleagues, I would say that my 5 most important elements of success for this treatment would include the use of YAG laser with coaxial illumination, the use of very high energy, including like 6.5 millijoule and triple burst. But at the same time, I'm playing with the offset on a regular basis, and I'm not cutting, I'm vaporizing floaters. So let me thank you very much for this part. And I guess it's the perfect opportunity to continue.
Okay, so the question was, from my presentation, how do floaters impact one's vision? Should we treat them? As a retina surgeon, I think we see those patients with geographic atrophy, with macular pucker, macular edema. We have patients with retinal vein occlusions, macular holes, and their complaints are scotomas and metamorphopsia, and also we have a decreased visual acuity. The typical floater patient has a visual acuity of 20/20, and when we look to the optic nerve and the fovea and the OCT of the macula, everything seems fine, because we are supposed to look through the vitreous and not into the vitreous. And as you can see here, there are some floaters on the left side and a little bit above the fovea in the OCTs. Sometimes the patients come with drawings of their floaters. Sometimes they give their names. So our goal has to be to capture those floaters and compare it with these drawings. And sometimes you really see the drawings when you look through the fundus photography of your wide field camera. And I think it's a very helpful tool that we can see the floaters in this wide field images and also in the OCT, and also show it to the patients. So the question is how the floaters impact one's vision. And this is the theoretical approach. Floaters induce light scattering in eye's optical media. That means we have retinal stray light. We have visual complaints such as hazy vision, color and contrast loss. We have glare. And most of the patients have also problems with facial recognitions. And when we look to the picture of the right side, you see that the floaters have these shadows on the retina, and this depends on the size of the floaters, of the distance to the retina, and also of the pupil size. Another problem with floaters are posterior vitreous detachment, and as you can see here in the ultrasound. And when you look carefully to the slit lamp, then you see also this vitreous detachment as a curtain, and this little bit so flying away in the vitreous. And you can imagine this curtain will have for the patients reflections and also stray light. So the visual acuity, measuring the visual acuity is not the best tool for the patient's vision. So we have to look for the contrast sensitivity. And there are some studies done with contrast sensitivity and floaters, as you can see here. And you see that patients with vitreous floaters has a decreased contrast sensitivity. You see the Weber score, and when you have a high Weber score, then that means that you have worse contrast sensitivity. And in this picture, you see the effect of floaterectomy. In this case, it's limited vitrectomy. That means when you diminish the floaters, then the contrast sensitivity will be better, will improve. Also with contrast sensitivity, there are some difference in those patients. We have to look for it. So we can see that we can compare patients, non-myopic patients with floaters. Then we have the myopic patients with floaters. Then we have non-myopic patients with PVD. And also the worst case is if you have myopic patients with floaters and a posterior vitreal detachment. What about the quality of life? Sometimes we don't take these patients very seriously when we see patients with retinal detachment and with geographic atrophy. But this is a nice paper, a study which have been done, and the patients were asked, what are you willing to do that you will be floater-free? And patients are willing to take 7% of risk of blindness for a surgery, younger patient a little bit more. 11% of patients take a risk of death, also for the younger patient. And the trade-off is 1 of every 10 years of the remaining life. That means floaters have real an impact in the quality of life on those patients. Floater patients are patients like with glaucoma or with AMD. You can also compare their stress with patients with a systemic diseases, like in this picture you see patients with stroke or cancer or with HIV. What we also found is, and here the colleagues, is that the quality of life and the trade-off were found in people with employment. Years of education plays an important role, also the age and the best corrected visual acuity. When the best corrected visual acuity is 0.6, you're at the barrier for reading performance, for a good reading performance. And when you have floaters, then this contrast sensitivity, which will diminish, makes problems for the patients for reading. We've done also a study here in Germany where we look for the quality of life and the extent of subjective impairment. And as you can see here, also the younger patients are more with the problems with the floaters, and also the employees, they are more have impairments in their life. So the big question is, can we improve the quality of life by treating the floaters? And the clear answer is yes, we can. And here are a study published this year, and you see the effect of the laser vitreolysis. You see here that after the vitreolysis, you have an improvement in the health-related quality of life, and also a decrease in stress for the patient. And interestingly, you find also a high effect in those patients with myopic patients. For pars-plana vitrectomy, you find the same results. Here, 73% of the patients have this severe or very severe daily symptoms. most effective activities are reading and driving. And after the vitrectomy, post-operative, most of the patients, nearly 100%, rated the experience as complete success. So the question was how do floaters impact one's vision? I think the question is more one's quality of life. It's comparable to systemic diseases. So we have to take patients with symptomatic floaters seriously. And we have to take into account their personal situation like age, employment, and myopia. And as Jerry Sivak stated, that floaters should be regarded as a disease, not just a nuance. I think that's very important. That makes sense that we really treat those patients, they are really symptomatic. Thank you very much.
Thank you so much. Great presentation, and I guess influencing quality of life and measuring it is one of the biggest potential problems for the future work, because we're still trying to measure the effect of procedures like laser vitreolysis, still having many patients with 20/20 vision or over 20/20 vision, and being unhappy with the way they see. So how do you talk to those patients in the beginning? Like, what can you promise and what you shouldn't promise?
I think the first thing is that you show in this picture the floaters that you see in the OCT images and also in the photography. I think that's the first step. Then you have to talk to them and say that it's not dangerous. That's the second step. And then I think you have to solve the problems. I give the patients for the first treatment atropine, low dose, and then I look if it's possible to do the vitreolysis. And if not, then I take the vitrectomy as an opportunity to take off the floaters.
I guess your experience with low concentration atropine is well known, and I guess your studies in this field show that even if it's still a way of managing those patients, there is still a huge place for invasive procedure like vitreolysis or even vitrectomy if necessary. So thank you very much for sharing, especially the parts regarding the quality of life. Roxana, we know that you have many years of experience in vitreolysis. When it comes to your patients, do you feel that it's just quality of life which matters in the way they actually function on a daily basis, or it's typically ophthalmic reasons why they come to you and say, I feel I have a disease in the eye? Is it more like quality of life, or do you feel it's like a disease?
I cannot say that it's a disease, but I think first of all, it's a quality of life, because there are a lot of young patients, and maybe I don't know if disease is the word that we have to use it, but I think the quality of life is, of course, the first problem.
The most important.
Because I know from experience, when I treated a patient, they are very happy. Some patients, they are under antidepressive medicine, and they let them the medicine away after the treatment. So it's a very yes.
So how to treat them? Let us know.
I start just a moment. Okay. So good evening to everyone. Thank you, Andrew, for the introduction, and thank you, Quantel, for the invitation. I'm happy to be here, actually, to share my experience with laser vitreolysis. I started, I think, about 6 years ago, in 2014, when the laser come on the market, and at that time, we didn't have any kind of informative material, so we don't have articles, we don't have papers, we don't have any studies, we don't have any movies. So my first experience with the laser and the patient was quite difficult, because I actually didn't know how to do it, what I have to see, what will happen, and yes, these movies shows exactly my feeling that I have when I fired for the first time. I saw that I will be explode, but nothing happened. So I treated far away, and now we have a lot of publication. We have the first study that was published in 2017, I think, from Professor Shah. And they have a randomized study where they treat about 36 patients, and they compare with another control group, and they show that the symptoms from the vitreous floaters improves after the laser vitreolysis. As Dr. Kaymak showed in his presentation, another group of doctors that are coming from Spain made a comparison of the quality of life in the patient before and after laser vitreolysis, and the quality of life improved after the therapy. Another study, it's ongoing now in Canada. It's conducted by Dr. Chowdhury. He is a well-known vitreoretinal specialist there. They have 35 patients, and they treated with laser vitreolysis and have a control group. They have the same results after the laser vitreolysis. The best correct visual acuity and the OCT images improved. The data from this study will come next year, so we'll know more. And another group of doctors from Greek doctors, they make an overview from the safety and efficacy of the YAG vitreolysis, and they conclude that by carefully selection of the patient, the laser therapy is safety and it's effective, but we still need new studies or more studies that have to establish the role of the laser vitreolysis for the therapy of floaters. So these are my patients, my experience. I laser more than 60 patients. 60% of the patient was phakic, 3% had refractive surgery, and 37 have had cataract surgery with monofocal lens or multifocal IOLs. The age was 52 plus minus 10 years, and the refraction minus tridioptry plus minus 4.6 diopters. I didn't have too much complication. The most of them was keratopathy because we use the lens to put it on the eye. So it's normally to have this. I touched the retina 2 times and I touched the lens 1 time. This complication I had them in the first 4 patients because we didn't have the experience. We didn't have any ioporise, we don't have macular edema, we don't have any retinal detachment, so and no other complication. So if you want to choose the right patient, we have to examine the patient very carefully. The anamnesis is very important because we are not allowed to laser the patient that have compliance less than 6 months. It's important to ask the patient how the floater are, because you can choose the patient that are suitable for vitreolysis from the beginning. So there are patients that are describing a very well-defined point or cloudy, they are moving with eye movements, and there are other one there that describe a haze or something that it's not so good defined, and you can you know exactly that they are not suitable for the vitreolysis. Then we go with usual investigation, refraction, eye pressure, slit lamp examination, and for young patient we can put atropine, low doses. I make it with Dr. Kaymak because you can see if the symptoms are better after the atropine or improves. So we wait about 30-40 minutes, then we ask again, and then after that we delay the patient with mitradium to have a very dilated pupil in order to examine the retina. OCT is very important for young patients too, because as all of us know, so when we look at the patient, we don't see anything actually at the slit lamp or in the fundus photography. But when we make an OCT, in the bursa premacularis are a lot of floaters, they are floating there. And when we show the patient that they will calm down, we go further with wide angle fundus photography in all direction. And an IOL muscle, it's not bad because you can touch the lens, and then you have the measurement before the cataract surgery. If you want more accuracy in the diagnostic, we can make contrast sensitive function ultrasound, because we know that bothersome vitreous floaters have 60% great echo density. And if you want to know if the therapy works or not, we make the questionnaire. There are some standard questionnaire from the National Eye Institute, the VVQ 25 or 39, or even we can make our own floater questionnaire. Oops. So, oops. This is my classification that I take in account, because for me everything is important: origin, localization, morphology, and number and dimension of the floater, because they are helping me choosing the patient that are best suited for the laser therapy. As we know, we have primary and secondary floater. The primary, we found it in young patient with myopia, or in PVD, or in some vitreoretinal pathology, and the other one in vitreous hemorrhage or operculum after the intravitreal injection, after YAG capsulotomy, in tumor or inflammatory diseases. Localization, it's very important because, as you say, Andy, we cannot laser behind the lens 3 millimeter and in front of the retina 3 millimeter. We can only laser in the mid vitreous. There, it's a safe position. This is actually the most problematic issue in the vitreolysis, because we cannot, at the beginning, you cannot say exactly where the floaters are, but there are some doctors, Russian doctor, they try to make mathematical algorithm to find where the floaters are, and they take about 30 patient with Weiss ring, and they measure the distance from the floater to the lens, and from the floater to the retina with ultrasound. And after that, they put the patient on the slit lamp, and they turn the ocular. When the floater was behind the lens, they turn the ocular about, they focus the floater with an ocular by -6 dioptry, and then turn and to positive. And when the floater was in front of the retina, they focus the floater with, I think, -6 dioptry, or the ocular power, and then they rotate the ocular in plus. And then the dioptry they transform in millimeter, and they compare this measurement with the ultrasound measurement, and they was quite similar. They are working farther away, and I think it will be a very good tool when we will know precisely where the floaters are, especially when we are at the beginning. Morphology is important too, because we categorize here in well-defined, cloudy-like, and diffuse. We have diffuse in all the cavity of the vitreous, and when we see something like that, we send the patient direct to the vitreoretinal surgeon. For an example here, we compare the floater with the cloudy. If you see something like that on the sky, and something like that in the eye, these are the beautiful floater to laser. So you have very good rate of success in this kind of floater. If we will see something like that, it's the same. We will send the patient direct to Dr. Kaymak, so to vitreoretinal surgeon. The number and dimension is important only to estimate your rate of success. When we have small floater and not so many, we will have greater results than if they are too much. So the first patient that we have to do when we start, it's a primary floater, localized in mid-vitreous, well-defined, a vice ring or cloudy-like, and I said the smaller and less, the better the result. You have to exclude any active retinal pathology or active inflammation and symptoms less than 6 months. And when you start to treat, you dilate the pupil, you put some anestheticum, and you use one of these kind of lenses. I'm using now only this thing mid-vitreous because I have an overview of the all vitreous. When you start an anterior, you use lower energy, and when we advance toward the retina, we can put we can go with the energy higher till 5 till 6 millijoule for posterior floaters. A treatment session lasts 5 till 15 minutes. At the beginning, you can take a little bit more time, not to have stress. You need several sessions, and I don't do any therapy after the treatment. Regarding the offset, I use only now I use almost the 0 offset, but when we have floaters behind the lens, we go with offset posterior, and when we have a floater in front of the retina, we go with offset a little bit anterior. The energy, you can use it, I spoke a little bit how to use it, but you can use it at the beginning in a single mode. When you feel more comfortable, you can go in burst mode, then you have more, and you treat a little bit, yes. I forgot the word, quickly. So this is another concept that you have to know on axis and off axis. Why is that important? Because if you see here the floater, you are in an on-axis mode, and now you turn in off-axis, you can see better the floater they are anterior. And here it's resume or between on-axis and off-axis. So on-axis view, we use it only for almost for middle and posterior vitreous, and off-axis, it's very good for the anterior floaters. These are my settings for the treatment. So a laser energy for one pulse mode is 5 millijoule, and I go in burst mode, 3 burst mode, 50 millijoule. You can see here, this is the floater. I start always on the top, and these are the bubble gas. This means that the therapy is efficient. These are the spots per session, between 500 and 2000. Please, at the beginning, remain under 500 because it's take a lot of time at the beginning. And this is the total power, the total energy that I fire in the eye. But as you see here, it's a lot of amount. Still, we don't have no macular edema, and this is the lens that I use. These are some examples. So this is a patient, 60 years old with vice ring. Here we have the ring, the floater, and I performed only one session, and the floater goes away. Here it's another patient, 39 years old. He didn't want to have a vitrectomy. You see a cloudy like here, you see here the shadow that we have on the retina. And after the therapy, we don't have any floaters. Patient was very happy. Another patient with retinal degeneration and a lot of retina hole here, he had laser coagulation. And here you see a big floaters. he didn't want to have vitrectomy. We lasered and he was very happy. 2 or 3 sessions. This is another patient with asteroid hyalosis. As we know, I tried to treat this, but with the laser it doesn't work. But the patient wasn't disturbed from the deposit. She was disturbed from the PVD. He is a vice ring, and I treated, and the patient was happy. And this is another patient. It's a very young patient. The other eye was operated from Dr. Klabe, and on this eye we didn't want it to have any operation because he had a full vision, and he had here a vitreous strength in front of the macula. You see here the shadow, and I cut it with the laser, and the strand didn't. When I cut the laser, the patient didn't have the shadow on the retina anymore, and he doesn't have any compliance anymore. And this is the problem. The laser beam, I focused on the strand, and I think I lasered I make about 10 shots in the eye. So as take-home message, even if you have a small floater, at the beginning allow plenty of time, a little bit more time. There is always more material present than we think. If you have a restless patient, you can perform parabolic anesthesia. You have to make IOL master for fake patient at the beginning, and do not promise too much. So laser vitreolysis is a safe procedure if you choose the right patient. It's an alternative to therapy for vitrectomy, and complications are very rare. And as here Dr. Andrew show a little bit at the beginning, this is our society, and here are the members. And if you want to be a member, you can here register, and we will be happy to have you as many members as possible. Thank you for attention.
Thank you so much, Roxana. Excellent presentation. And I'm more than happy that we are still using very similar settings for the laser. I saw you still using my recommendations from many years ago, and it's very good for us that we have very similar clinical experiences, and at the same time, even if we have sometimes very different methods, we have similar outcomes. There are a couple of questions on Q&A, but I think we can get back to them at the end during Q&A session. Just one question which still appears in my mind. If you're recommending a good starting point for someone who wants to go on with vitreolysis, are you recommending to start generally only with vice rings or any other types of floaters which would be suitable for the beginner?
Only with vice ring or this cloud-like, because at the beginning you don't know what will happen, how the vitreous will react and something like that. And it's better to start with the vice ring.
Excellent, thank you so much.
And the fake patient, because
exactly, because of the lens.
Yes.
I guess we have the same feelings. Okay, so so my next question would be to Karsten. Can you explain us a little bit, because you're going to speak about technology. You have a lot of experience in clinical part of ophthalmology, and you remember lots of types of YAG lasers in the past. How the use of coaxial illumination has changed your practice? Is it really a game changer, or it's just a slight change in your practice right now?
In my opinion, it started as a little an add-on. So, but I still use it more and more, not only for vitreolysis, but as well as for the standard PCO capsulotomy. And I don't want to miss it at all at the moment.
Okay, so we would be grateful if you could present a couple of your thoughts regarding both topics.
Roxana hosts me, so then can I start?
Okay. So we know you're going to speak not just about the technology, but about capsulotomies, HD capsulotomies right now. So please.
Okay, thank you first of all to Andrzej for hosting this meeting. Thank to Contel for inviting us and gave us the opportunity to present our ideas on not only on vitreolysis. So as Andrzej told you, I have to give a short talk about what changed in YAG lasers. At the moment, the Quantel offers two different Alex Ultra Q platforms. The Ultra Q Reflex, a single YAG laser, and the second one is the Tango Reflex. It's a combination of an neodymium YAG laser and an SLT laser, which makes it easy to perform as well glaucoma laser surgery. The both platforms, it had to be mentioned, offers all the technology we will talk about, the reflex technology, the new focusing system. You need offset settings and ultra Gaussian beam profile. Let's go a little bit to basic and have a closer look. What is a neodymium YAG laser? You all know it's an abbreviation, means neodymium doped yttrium aluminium garnet. It's an alloy that forms crystal, as you see below, not very shiny, not very pretty, but they work. The first YAG laser was introduced 1964 by the Bell Institute in New Jersey, US. It's a solid state laser emitting a wavelength of 1064 nanometer, that means in infrared. And you are able to optically pump the laser with a flashlight or a laser diode. Most available laser, as the Alex as well, are pumped by laser diode. It's more stable, it makes it portable, it makes the system smaller. The maximum power achieved with a neodymium YAG laser was about 250 megawatts, means 250 megajoule per second. So, and if you see in our settings, we work with 5 to 10 millijoule max. You see how powerful a YAG laser could be. There are typically two work modes, the continuous mode and the more common Q-switched mode, pulsed mode, which offers higher max energy at the pulses. As a frequency doubled laser, it's emitting 532, means green light, similar to argon green laser, and it's suitable then as a laser for retinal coagulation. We have a wide range of medical use, not only in ophthalmology, dermatology, urology, gynecology, and so on, using neodymium YAG laser but mostly with higher energy settings. Here we see the laser beam system. The laser light will be delivered by a laser fiber, and with the help of a collimator lens and a focusing lens, the laser beam will narrowed and focused and form to a spot. And we have not only a spot, we have these Gaussian beam profile where in the center the highest energy level is delivered, and this energy level is so high that it's able to form a plasma we're using during the laser treatment. The form and the character of the plasma depends on energy and on different other parameters. The laser offers YAG laser usually plasma of about 10 million Kelvin temperature, and on the right sketch you see the plasma effect of different energy settings, and that is, I think, important as well as in theory as well as in treatment, especially if we talk about a treatment to a safe treatment and not to disturb surrounding structures. So the convergence zone, as I mentioned, is the zone of highest energy, and we have two effects in these, the so-called nanosecond domain. The first effect is the plasma formation with very high energy, and the second one is the microsecond domain, the forming of small gas bubbles, and these causes an acoustic shock wave mostly used probably in capsulotomy. So there are some special settings in the energy delivery of the LX laser, the so-called ultra Gaussian beam profile. That means it's narrower. We achieve at a faster time a higher energy level and form the plasma much easier, because the rising time of the energy level and the sharpness of the Gaussian beam profile are the main criteria that depends the plasma forming. Both are optimized with the Ultra Q technology to get a plasma effect earlier with lower maximum energy. So here we see a sketch of a standard YAG laser with these plasma forming effect. Goes toward to the laser beam, that is important to know, and the acoustic show wave compared to the Ultra Q reflex, a smaller plasma effect, a smaller shock wave, so more precise treatment on one spot and lower surrounding damage in the tissue. If you have a small effect only, it's very important that you have a good focusing system, especially if you think about doing not only Vitreolys but PCO treatment as well. In modern lenses, for example, multifocal lenses, diffractive lenses, it's very hard if you have a focusing system that doesn't gives you a perfect image and the perfect focus point. The LX laser works with a 2-point focusing systems with a very low tolerance rate of ±8 microns. And that gives you in nearly every situation a perfect image of both to focusing and to treat perfect. The offset system was already mentioned by Roxana. The LX laser is the only on the market available laser with an anterior and posterior offset of up to 500 microns, which makes it very easy to treat the vitreous, but as well the posterior capsule without damaging the lens material. So, and the illumination system also mentioned before, the Reflex technology with this coaxial illumination, where you are able to have the treatment beam and the observation beam in the same direction. And here's a short video how Alex mentioned this problem. You see this small swiping mirror, which swipes out in the moment the laser comes from here. The laser beam is delivered to the eye here in slow-mo again. With every shoot, the mirror goes down, and so you're able to work coaxial. So to compare again both laser systems, we have with the standard laser, we have the standard Gaussian profile compared to an ultra Gaussian profile, which is faster and in rising and less energy needed. The optical breakdown is much earlier, 1.8 millijoule in air with the Ultra Q reflex compared to about 3 to 4 with the standard laser. And the standard laser source offers in most cases variable energy levels because they don't have these active cooling system as the LX laser. We have the opportunity of the coaxial on-axis and off-axis treatment with the LX laser. We have these offset posterior and anterior of about 500 microns, and the offset will be managed by an optical lens, not by a prism, that offers a lower aberration and better optical quality. So, and that's why the ultra-Q reflex technology, as shown before, is not only useful for the treatment of the posterior capsule for PCO, but also in glaucoma for peripheral iridotomy, and as well for vitreous for membranotomy, vaporize the vitreous. So if there are no questions to this boring physics, we can proceed with premium capsulotomy. It sounds simple, but so during the last years, and was able to use since about 6 years the LX laser, the management of the capsulotomy changed in my hands completely. So as I start 25 years ago with the capsulotomy, we puncture with 5 shots, and that's what, a pinhole opening, and that's fine. But that wouldn't work, especially in lenses with special optics, multifocal lenses, and so on. So what we have to know about the posterior capsular purification development, there are multiple risk factors, the age of the patient. You know, everybody knows a young patient will immediately develops a PCO. That's why we do during surgery a primary open of the posterior capsule. But immediately, if you have done your cataract surgery, you induce effects on the remaining lens epithelium that delivers different factors that starts or let the epithelium grow again and form different kinds of collagen, and that will cause in the PCO, as seen here with different illuminations. And we see here a fibrotic and a proliferative PCO. And this image, you can see the difference of a coaxial and on-axis and off-axis illumination also for treatment. So that is a typical quick and dirty capsulotomy done within 10 seconds, 5 shoot. A little bit too small, especially we see here a patient with a multifocal intraocular lens. The capsulotomy is decentrated. There are remaining capsular tears very close to the center. We see here multiple damages, yuck pins, and this one here is forming a secondary floater. So, okay, we opened the capsule, but I think we didn't solve the problem. Here we have a video sequence from Paul Zing showing, and that is an excellent example of premium capsulotomy, because this patient shows as well an asteroid hyalosis, and so the vitreous is very good visible, and with the change of the illumination you have seen there are still some remaining capsular tears running around, and this will form floaters and disturb the patient, especially in patients with IOLs with modern optics. They will be disturbed very much, and we know that a small amount of PCO is disturbing them. But if you do this and remain all these particles inside the optical axis, you don't solve the problem. So question, does size matters in a capsulotomy? So not in the way that the visual acuity will become better. There is no change as shown here in the paper from Hayashi, but there is a significant improvement in contrast and glare visual acuity after an enlargement. And that is one of the arguments to enlarge as much as possible the capsulotomy. A second aspect, as mentioned before, how about laser damage? And shown here from a paper from recently published a couple of weeks ago from Borkenstein and Borkenstein, shown here 2 examples of a laser impact. On the left, on the hydrophilic, more like a bullet hole, and the glass break on an hydrophobic intraocular lens. And you can imagine that there will be an effect on visual acuity, especially if they are in the optical axis in the center of the lens. And they measure this, and there is a significant influence on image quality, especially halo, starburst, and glare. And on the right side, you can see these white spots on the wavefront analysis. And these wavefront, these white spots are these laser impacts on the intraocular lens. So we have an understanding now of the effect on optical quality due to an incorrect working capsulotomy. So it's important that we are able to do laser with low energy possible. That means we have an excellent plasma formation with low energy, and we have a good focusing system that we don't need high energy. And the focusing system helps us to treat, like shown on the right side, multifocal or EDOF optics. The rapid pulse rate makes it easier for a fast treatment, and coaxial laser technique and enables on and off axis treatment, which may helpful, especially in dense PCO. Thank you for your kind attention.
Thank you so much. Absolutely great material, and I fully agree that modern lens solutions, including so many patients being treated with EDOF lenses and multifocal lenses, require very precise capsulotomies. And I see that in my practice as well, as right now in my private practice, it's about 60 to 70% of EDOF and multifocals. So those patients are coming back for not just a regular capsulotomy, which can be performed everywhere. They need to get a very high quality, precise treatment, which requires extremely good quality of laser, not just the use of coaxial illumination, but in many aspects, the combination of on-axis and off-axis treatment in the same way as we do it for vitreolysis procedure. And I hope you agree that the introduction of coaxial illumination changed this practice.
Absolutely.
Right. Thank you so much. I just have one question at this point, because there was a question in chat regarding the lenses, and I guess it's a perfect moment to talk about our preferences in vitreolysis. So Roxana, you mentioned you're using a Sing lens in all of your treatments. Same for me.
Yes, I started with Karikov 25 and Karikov 30 millimeters of axis, but you have, I couldn't know where I am, so I'm feeling more comfortable with seeing mid-vitreous.
I had exactly the same pathway. How about you, gentlemen?
Yes, I was lost with the other lenses.
Lost in space.
So I just leave Roxana on their own. She was just working on the best lens, and then I adapted.
Okay, so she was a pioneer.
Yes, I let her be the pioneer.
Thank you.
Same on me. The Sing lens is the most suitable.
So I think that the introduction of Paul Sing's lens really changed our practice, because before that we were using so many lenses for different applications, and right now it's basically one lens for whatever you want to do, no matter if it's a Y-string or a floater, which is right behind the lens, right? So I guess it's a perfect addition to our practice. There was a second question in our chats, which is slightly different, asking about vitreomacular traction. Can we treat it with the YAG laser? And I have to tell you from my personal experience that I tried it a couple of times with very different outcomes. And generally, I have to admit that if the traction is non-transparent, I don't feel that confident with such applications being like 100 or 200 microns in front of the retina. Maybe you have more experience with the retina, as you're very famous for your retinal papers and work. How about you?
So if you want to try to be minimally invasive, then give just a small gas bubble in the eye. I think that could be enough before you will start doing your vitrectomy with gas.
Yeah, exactly. I think we cannot just say that YAG laser is intended to be used for every application. It's not working like that. So we are asking all participants to use the Q&A to ask the questions. We are more than likely and open to help you and answer them. When it comes to the instruments, oh, there's one more. Have we found it's necessary to use more energy in a patient with a more viscous vitreous than an older patient with a more fluid vitreous? Who is willing to answer? Have we found it necessary to use more energy in a patient with a more viscous vitreous than an older patient? I guess when it comes to young patients, they are very hard group to treat in general, because in many of those eyes, that vitreous is almost clear, and there is sometimes only very small opacity, and the visualization is the most important problem which you can find out. How about your experiences? How many of patients who are under 30 years of age are you treating?
I think you are absolutely right. The visualization is much harder in younger patients, and so if you are able to identify a floater, I think it's then you decide the energy, but it's not a difference in energy level on older or younger patient. But younger patients are harder to treat. Absolutely.
And I think it's not just a matter of viscosity, it's just a matter of visualization rather than the aspects of how the vitreous is constructed when it comes to the collagen structure, right?
Yeah.
Exactly. Thank you for the question. When it comes to the differences between different types of YAG lasers, I have to admit I had the experience with standard YAG lasers before the introduction of coaxial illumination and before Alex introduced ultra-Q reflex. And my time with Vitreolys before that was really hard, and I failed 2 times, and I talked about it many times, and I wasn't happy with the outcomes. I felt the procedure is very dangerous because the off floater focus of the laser was, for me, something I cannot predict. So that was the main reason why switching to coaxial illumination made a difference. And both ultra-Q reflex and right now the laser I'm using, the Tango reflex, are my lasers of choice in this case. We have another question, which is, has anyone experienced retinal tear while doing vitreolysis? Have you seen any retinal tear while doing vitreolysis?
No, not at all. And we exclude it anyway before we treat. So we examine the retina very carefully.
That's very important. I believe that you need to see the periphery of the retina by yourself. And I'm using the Zeiss Clarus in patients where I have doubts to cover majority of the retina, just to see something what I could have missed. But at the same time, the self-examination of the retina really makes sense in such cases. I remember the story of a patient who was mentioned by Paul Singh. So he had a patient who came to him for a vitreolysis procedure, and he examined her, nothing in the periphery, but finally the procedure was done a couple of months later. And he thought that maybe before performing the procedure, he would see the retinal periphery again. And guess what he found? A retinal tear. And generally, if he performed vitreolysis procedure, then everyone would say the vitreolysis caused the retinal tear, right? So sometimes we need to be extremely precise in our examination.
Yes.
Yes.
Very important.
So what we have seen, Roxana showed, I think, an example of, there was another question of a retinal impact. So fortunately, you see a little bleeding, or we have seen a little bleeding, sometimes a bleeding as well as into vitreous cavity, but it recovers, I think in every case we have seen this.
So we didn't speak about the complication here. There are some complications. When I touched the retina, I think we have bleeding, but individuals too. And we perform an OCT to see if we have a retina hole, and we didn't perform it. We didn't perform any laser coagulation around to surround the bleeding. And I think it takes about 3 to 4 months till the bleeding was gone. And the patient didn't have any kind of problems because where I thought the lens was nasal from the optic nerve. So
I think it's a generally very important remark that when you hit the retina, and I heard the story from many of my colleagues, I had the chance to observe one of the patients referred by one of my colleagues, that within the first days you can see the subretinal blood, a little bit of bleeding, which self-limits, and there is absolutely no need to coagulate the retina at this point. You just observe it. I've been doing a couple of OCT scans in the meantime, and it's just a very small scar at the retinal pigment epithelium level at the end, and a majority of patients would not even see the scotoma in their visual field. And I think it's another beauty of this procedure, that even if you'd go too far in your learning curve, it's not really dangerous for the patient function. I guess you have seen it. Okay, another question. Do you first fragment the floater with a lower energy setting and then vaporize it? Or you use 5 millijoule from the start? What would you say?
Because I'm routine, I do it routinely. I start it. Actually, you can start with low energy and go and go high, and to see until you have bubble gas, if you are feeling comfortable. But I'm starting always with 5 millijoule.
For me, it's even 6 and triple.
5.5.
Yes.
Okay, you won.
So, because I think the experience, you have the experience, you know how to deal it, and you go fast. I go in burst mode from the beginning on. So no.
I guess we all.
Yeah, I think it doesn't make any sense to start with low energy, so you don't see any effect, especially if you go down the eye. So we lose energy by passing the vitreous, and so if you start with 2 millijoule, there will be no effect, and that's why it's absolutely right. 4 to 6 is a good, and then you can start with a single shot and add then the burst function.
Yes.
Exactly. And there is another question asking us whether we are cutting or vaporizing floaters. I guess it's very important to say that vitreolysis procedure is intended to vaporize the floaters. And if you're just saying that you cut them, it means that you're using too low energy. And so obviously, if you have very large floaters, it's easier to cut them first and then vaporize piece by piece, as it happens in NUI rings. But generally, we want to vaporize that floater. I guess you agree.
Absolutely.
Okay, another question. What about vitreolysis in hypermetropes? Any precautions? Any comments from your side?
No. I don't
really, I guess.
Difference between.
I think it's possible. The treatment area is smaller because the eye is shorter. That's it.
But we treat hypermetropes.
Maybe about it's the question if they have if they will have a glaucoma or something like that, or maybe you have eye pressure goes high because the eye is a little bit smaller than the myop. I don't know, but I don't make any difference between them.
I guess we haven't seen such problems, and basically if it's a patient with closed angle glaucoma I would be extremely careful with doing anything right behind the lens, because we know that influences the ciliary body. But generally, when it comes to vitreolysis of a Y-string, it should work in the same way.
Yes.
Okay, so the last one would be, which floater is best to start, a central one or peripheral? I'm very curious what you're gonna say.
I think we start central at the beginning because if it's a little bit in the periphery, you have to move the eye or the lens to have in focus, and you need experience for that.
You have to shake the head that the peripheral get central.
Or something like that.
The funny thing with floaters in the periphery is they don't disturb the patient.
Exactly.
You
And
don't
I think
have to treat it.
If the floater appears in the center, it's the perfect location to vaporize. So I would definitely start from the center, vaporize it, and then look for any peripheral floaters which might be vaporized. But then that's actually the second row, right?
Right.
Okay. I'm really amazed by the number of questions you have. So thank you again for that. And I guess it all helped us in understanding your needs regarding vitreolysis procedure. I don't see any further questions. So maybe, if possible, I would get back to that very important, I guess, slide, which is talking about the IOFS webinar, which I showed in the beginning. So if you agree, I would get back to it. And let me share the screen. Okay. I hope you can see it. So so again, because we are all members of IOFS, and we want to invite you again to visit our website. As Roxana mentioned, please scan the QR code to make it easier. And you are all invited to join our webinar on 27th of November. You can see a very distinguished panel, including Professor Tassignon. You can see that Dr. Brasse is coming, Dr. Paul Singh will join us, and Dr. Conrad as well. So many people who spend years of their professional life treating floaters and who want to share their experience. So I guess we all agree that it will be a perfect opportunity to have a wonderful Q&A session at the end, like the one we had right now.
We'll make a Saturday party floater.
Exactly, exactly.
Yes. Thank you, Quantel, one more time. And thank you.
Thank you so much again. I would like to express my gratitude to Quantel. That's even if the topic is still hard and still there are many controversies regarding vitreolysis, we are all happy that it's actually a CE marked procedure. So it's a legal procedure. It's on-label procedure, and we are performing that in Europe on that basis. So we are more than confident to speak about our outcomes, and I guess you will see that in November when we're going to have even a larger panel. So thank you all for joining, and hope to see you in November.
Have a beautiful weekend.
Thank you, everyone. Good night.
Bye.
Good night. Bye-bye.